I work and live locally here to Liverpool. I'm based in the Clatterbridge Cancer Centre, which is the tertiary oncology centre that's centralised in Liverpool city centre, but we also have a branch over at the Wirral site. I've worked 25 years in oncology, a few roles for Macmillan, a few for what was the Strategic Network before it became the Cancer Alliance. I'm a therapy radiographer by background, and that's really where the birth of my fire in my belly for patients with spinal cord compression came. I worked as part of the pre-treatment team who plan and treat patients who are having radiotherapy treatment as their spinal emergency intervention, and it was always very last minute. It was always a very negative experience for the patient, and we always seem to have missed our opportunity, that window for the intervention. Patients would arrive, they would have already lost their bladder and bowel function and be incontinent and have lost their power, and it felt very much like it was we'd already missed that window. So when the NICE guidelines came out in 2008, the primary recommendation was that each region would have a coordinated service. And at the time, 2009, the Christie set up their service, and they had a 5-day service that supported their region to coordinate any patients who had confirmed metastatic spinal cord compression. So until 2017, no other region in the whole of the UK had a service, and then we started ours in 2017. There was a clinician who had a particular clinical interest in this, and myself, and for the first 6 months we just collated and scoped and seen how many referrals we had in the region. So we have 8 acute trusts in this region. We have a spinal surgical provision through Walton, and the Clatterbridge Cancer Centre is the tertiary centre for radiotherapy. We supported all of primary care, 34 community and hospice teams, and that gave us quite a few variations in route to referral, how quickly patients access services, etc. In that first 6 months, we had 178 referrals, and I can remember thinking, 178 people with a spinal cord compression, that's so many. And last year we hit 1,400 in the 12-month period. And I'll go on to explain why that increase has happened. So over the 7 years that we've developed the service, there's probably a handful of about 3 or 4 regions that have got a coordinated service. There's probably somewhere in the region of 70 tertiary centres throughout the UK. And still to this day, many of the routes for referral are to the spinal surgeons to ask if surgery is a treatment of choice. In the majority of cases, it's not, because patients are quite comorbid and not surgical candidates. So you quite often get a delay introduced at the very first port of contact, because 97% of the patients in our region are not surgical candidates. So the first thing we did was, the second 6 months of that first year, we created all the guidelines, created a route of referral, and we created what was a central point of contact through the tertiary centre. So instead of everybody getting a surgical opinion first, they got an oncology opinion, and then that oncology opinion determined those that needed surgery. Naturally, some kind of service improvement elements evolved, and what I'm going to talk about is what are the 3 main kind of pillars that our work has seemed to filter through to. So what's been in the impact both to patients and services, and what has been the leadership involved in that. And when I talk about leadership, I don't mean in a kind of strategic hierarchical way, but literally has the workforces kind of broadened, and we have lots of different disciplines feeding into that, how we've managed to create lots of leadership within that, and then how across a region we've managed to integrate the service. So when I talk about impact and I think around patients, I'm also talking short-term and long-term. For those that aren't familiar with spinal cord compression, it is one of the most common oncological emergencies. It's actually the most prevalent, but it's less well known compared to something like a neutropenic sepsis, because patients with a sepsis are very unwell and medically unstable, and so people tend to act quicker. Patients with spinal cord compression can most of the time be stable patients, but they just have a spinal emergency that's happened. It's a bit like having an acute event in a oncological way. The pictures on the left-hand side just describe the different ways that we can get cord compression, and the reason why it's important is because for us as a service, if you have a spine, you have cancer, and you have some kind of spinal issues, you're referred to our service. But for other services, the configuration of them are quite different. So some will only accept patients who have got confirmed cord compression, and they won't accept somebody who has potentially intramedullary disease or intradural disease. That would be considered more of a metastatic setting. We would accept anybody who had metastatic suspected spinal disease. This picture, I hope, will help to demonstrate the spectrum of severity. So the top diagram is a lovely diagrammatic format of a spinal through axial sectional axial slices that shows the red as cancer, and it just shows as the cancer progresses through the different layers of the spine into the spinal canal and the cord. It's called the ESCC grading system. It's a radiological tool. A lot of radiologists throughout the UK don't like using it. The reason why they don't like using it is because they feel like it forces them to standardise how they report when everybody else is crying out for them to standardise how it's reported. As you can see, the difference between the top layer and the bottom layer, what it really looks like on an MRI scan, is very different. And most clinical teams, unless you're used to working in spinal, aren't used to looking at the difference, and it's a very subtle change. So what clinicians are usually used to is the term bone mets, impending core compression and core compression. And the reason why it's really important that we just see it as a whole spectrum of cord compression is because you can be somewhere in that middle band, the impending, and have neurological symptoms, and you should be treated as much of as an emergency as if you were in the red zone. And quite often, patients are presented in ED, and they will have a scan done, and the report will describe, the canal is invaded, abutts up to cord, and uses strong language that describes a cord compression and then concludes no cord compression, because they mean no radiographical cord compression. And there is no correlation then with the patient's symptoms. And for us, we say if it's anywhere on that spectrum, ring through to us and we'll help determine who needs that emergency intervention and who can wait a week and who can be treated in a more palliative elective way. So trying to educate all of our referral routes, so primary care, acute and community trusts, that actually if they're somewhere on there, think of them as potentially an emergency, ring through, you've got the central point of contact, 7-day service, and we'll help determine who needs that emergency intervention. And when we started, the diagnosis of death was only 30 days in Cheshire and Merseyside, which was considerably lower than national average, which was sitting around 3 months. And we, over the last 7 years, have not created some magic drug. It's just the rapid coordination and the rapid wraparound service that we've been able to provide means that all of the different interfaces across the pathway are just speeded up a bit because it's centrally kind of supported. What that's done then is meant that people are identified much earlier, the diagnosis is much earlier, and it's translated into better outcomes. As we move to an ageing population where people are living longer, we have lots of patients coming through who are living with a very long cancer history as a long-term condition. On a daily basis, we have patients who have been referred who potentially had a breast cancer or a prostate cancer 10, 15, 20 years ago. And how do we make sure that we don't just think of this as an end-stage cancer complication, but actually, potentially, there's a lot of people who are ageing but very well, will have competing comorbidities, but will have their treatment boundaries pushed. As everything is, the landscape in cancer is changing, techniques are improving, systemic options are increasing, and it means that the decision-making is much more complex. You rely heavily on lots of reviewing around patients' frailty, their comorbidities, but also what's the whole array of treatment options available to the person. We think of time being precious for our patients, and absolutely that's always going to be our priority. But as ever, with our increasing capacity issues and the increased pressure on all of the services, it means that the wider system has never been under more pressure, and what we're having to do is make sure that we're being as resourceful with what we've got, and that actually means doubling what you've got with half the resource. So for the last 2 years, I've been part of the NICE committee in creating the new guidelines that were published last September. I was really keen. For the last 7 years, we've created a service that is a 7-day service. We've grown from just me being a single person to a team of 14. Our sole function is designated to just supporting the region around metastatic spinal malignancy. And as a result, the NICE guideline went on to use the Cheshire Merseyside data as a real-world model in the new NICE guideline. For me, that was really important to be part of because I wanted to share the tools that we'd created. I wanted to be able to take the learning that I'd had over the 7 years and what we'd done as a region and say, actually, how can we not only change national policy, but actually influence that on the ground? It's okay having a great guideline, but if you can't actually implement that, then it's no use, no ornament. So whilst we're centralised in the city centre, we are Our Cancer Alliance is one of 21 cancer alliances. We've got quite a large population. We also serve the Isle of Man. And I mentioned the different referral routes through to the centralised service. With that comes the unwarranted variation of each of those localities, variations that exist within those acute trusts and the different practices. So I'm going to talk around how the leadership layers within our model has helped standardise that variation. So for me, one of the drivers was you've got to do it as a layered approach. If you're going to nationally influence policy, then you want to make sure that you're maintaining those networks. So the Acute Oncology Society is a national society that's set up over the last probably 5 years that it's been running, that supports any clinical teams that work in an acute oncology setting. We're really fortunate that in our region we have really great acute oncology services in the acute trust. As a tertiary centre, for us and the Walton Spinal services, we don't have our eyes on the patient, so we rely really heavily on the clinical information and the assessments that are being done with those that actually have the patient in front of them to aid that decision making. It's really important that the networks that we've created throughout the UK, we keep those relationships open so that we can share this good practice, we can identify those gaps in service. So the NICE committee was a group of about 10 of us, of the core committee members, each from different disciplines with different specialties. And we've maintained the group, even though the guideline is written now, to be able to have that greater reach and be able to cascade and share that learning. So a few things that are unique about our service that other people are wanting to be able to use when they're having their commissioning conversations and to be able to demonstrate the benefit of the service. Everybody is competing for funds and the funds just aren't there. So how do you demonstrate the cost benefit of the service that you're trying to introduce? And we're quite fortunate that because NICE used the real world model, it had an absolute economic thrashing from their team. And what they were able to demonstrate is that it's a low cost, high impact initiative. Because although we're quite resource intensive, we've got a team of 14 and that's a dedicated service, the outcomes have really improved for patients to be statistically significant, and that we've reduced bed days, reduce those A&E admissions, and all of that cost of the emergency services is significantly less if it's more planned and more elective. So the resource is high, but actually the cost of that is significantly lower to the system. So for our service, we have a consultant clinical lead for a half PA that helps with kind of governance and sign off of a lot of our processes. I lead the service, but what the team really looks like operationally on the ground is we have created an MDT in the first layer. So our referral triage team consists of radiographers with different specialties, computer planning, diagnosis, and then also physios, nursing. And it means that when those initial referrals come in, you've already got that initial decision making to happen as part of an MDT. Most MDTs, and specifically in a cancer setting, are once a week where all the disciplines sit around a table and discuss the cases. Because of the time-critical nature of spinal cord compression, we don't have the luxury of waiting for the weekly MDT. It has to be something that's done in real time. When I first started, what that looked like was an A&E would ring the radiotherapy service and say this patient needs some radiotherapy. They'd come across, they'd go back. It was all very straightforward. Now, in real time, we liaise with up to 15 services per patient. In real time, we have between 4 and 10 referrals a day. So that requires quite a lot of coordination and quite a lot of virtual MDT. The second thing that's quite unique to our service is to always be moving forward and always keeping up with the rate of the transformational work and the rate of change in the system, because we have so many interfaces. We have employed our triage team to also have a additional workload of advanced practice. So all of them are band 7s. They form part of the coordination team, but they also carry a work stream of service improvement work. So for example, the education lead is a therapy radiographer by background. She has a computer planning specialty knowledge, but she's worked at the University of Liverpool as a lecturer for the last 6 years. So she's created our education strategy that we've cascaded across the region, and she's also created our bespoke education framework. There is some national standardisation around the frameworks that you'd use for different disciplines. So there's an ASM framework, the SN framework, there's an AHP one being created. But when you're a mixed discipline team, there is no framework that aligns exactly. So she's taken those nationally accredited frameworks and created a service bespoke one. Each of those different work streams then form part of our overall strategy. But what we've tried to do is make sure that personalised and co-produced care is as embedded as it possibly can be. It's quite difficult to do that in an emergency pathway. You know, patient's experience is quite difficult to capture when you're in the middle of an emergency and say, you know, what's worked well for you today and what hasn't worked so well. There's never really an appropriate time to do that. So that's taken a bit of thinking and a bit of co-producing with patients to say, actually, in today's journey, while you've been with us for the 10 hours, what would have felt like an okay time to ask you these questions? So as I mentioned before, those referrals come in from all of the different routes. The issue that we have about that, as I'm sure for everybody, is the different interfaces that we have, the different IT systems. That means that there isn't one single route of referral digitally. So the electronic referral pro forma is still in a very primitive format. That's part of a wider kind of digital regional work stream. That virtual MDT that we hold, we have a consultant assigned to us for the whole week, the same consultant for consistency and decision making. And whilst the advanced practitioners will pull together, you know, what the patient's current active treatment is, you know, how frail they are, what the referral information is, what the recent imaging has shown, what's the trajectory of their general cancer, is this a blip in their journey or actually have they been declining over some time? Previously, when the diagnosis to death was only 30 days, this was the intervention, so you didn't have to worry about re-irradiating. But now that patients are living longer, the treatment has become more complex in the planning because you're quite often re-irradiating an area for a second and sometimes third time. That daily MDT, so we have a morning MDT and then we have one as and when patients present throughout the day. That determines whether patients need same-day treatments, which will be logistically transferring them from wherever they are in an acute setting across to the site of intervention. The majority of cases it's for radiotherapy, or whether they need urgent intervention, which will be over a week. So the patients who have impending core compression with no neurology, we've got a bit of time to be able to plan their care. We're quite fortunate in our region as well in that we have a parallel radiotherapy service that's just for symptom control, so we can refer to that service as well. It gives us another layer to the service. I think one of the biggest shifts in the outcomes is related to this last part here, this more palliative elective. So patients present with suspected spinal cord compression, they have their assessment, they have their imaging, and it's found to be something a bit earlier because generally the teams are better at identifying those early red flags. Whereas previously it would have been a case of you have to wait until you see your oncologist, or actually you can have a single 8-grey radiotherapy session. Now it's enabling us to facilitate back with the parent teams. This has just happened in this patient's journey. Have we got chance now to go back and review what their other options are? And that going back to the drawing board and looking at what options are there and then has really impacted on the outcomes for patients, especially as the lines of systemic treatment and IO-therapy have increased. It means that there are more options available to people that there would have been previously. For us, one of the biggest positive impacts is having 2 cancer support workers on the team who are the patient's advocate. So when patients come across to the tertiary centre now, it's a brand new building, it's only been open a couple of years, but the patients pass through 5 different services. It's 9 clinical interfaces across 7 floors of a hospital, and that is a very extended day for the patient. They're there for around 10 hours. The treatment and planning of the treatment is complex, and it does take that long, and it's great that we can do that in real time, but that's a really terrible experience for a symptomatic patient who's in an environment that they don't know. And having those advocates with them, it means that the gap in between the planning and the treatment, we're unable to undertake a EHA and do more of their elective care planning with that EHA. The other positive impact is for the different clinical teams in the trust where those patients would be hitting. The nature of emergency work is you can't plan for it, so we can't say to the emergency teams how many patients we're going to have that day. Every team you go to are already full to capacity, so adding to that makes it more complex for them. Having these key workers means that it facilitates it for the teams as well. So the first layer of leadership is not just having an oversight framework from the clinical leader, myself, overseeing the whole service, but that the initial triage team are also clinical leaders in their own disciplines. So we're able to do that first level of assessment and decision making. So this depicts the 8 acute trusts and the Isle of Man that we support. And for us, I mentioned that the acute oncology teams are our eyes and ears on the ground. So we really heavily rely on the variety of teams where the patient presents, liaising with the acute oncology teams, who then will say, actually, this patient has a much more complex oncology picture, and actually, I think there's other things going on here, or actually, yes, I think it's appropriate for treatment and they're safe for transfer, etc., etc. So as I mentioned before, patient experience and capturing that, quite tricky. So there is a colleague from the NICE committee who works for the Cancer Alliance in Manchester, and she did her PhD in, or is doing her PhD in patient experience capture for those with a malignancy of unknown origin who develop spinal cord compression. So it's a very niche area, but if you can get it right for those patients, you can get it right for all of the other cord compression patients. So in Cheshire Merseyside, 20% of patients who are diagnosed with a metastatic spinal cord compression have a malignancy of unknown origin. That's their first presentation of cancer. So they have their assessment, they have their imaging, and we say you have a spinal emergency and you have a cancer diagnosis. But we can't tell you what your cancer diagnosis is because you need some biopsies and you need some further diagnostics. For the emergency patients, that emergency biopsy is really logistically difficult to make sure happens. If you have a clinically deteriorating patient, we have no choice but to irradiate them. But once you've given that radiotherapy, you will not get histology type from the obliterated cells, so you affect the overall management. So what we really want to be able to do is get a bone and spinal biopsy in the same day. It's quite technically difficult to do, and we rely very heavily on specialist service to be able to do that. So when my colleague has done this PhD, she's based it on a grounded theory approach where you ask a few patients what are the common things that work for them and what didn't, and then you grow your data set from the common issues that present for each of those patients' responses. We found that using that very basic what worked, what didn't work, anything else you want to say, brought us things that we didn't know were issues for patients. So the diagram on the left at the bottom shows a stand. It was a commercial product that was used for holding iPads. And we had a university student from the University of Liverpool who was doing a medical engineering degree, and he did a project on converting this commercialised stand to be able to be used for spinal patients who are flat. Our initial thought was that they could have a media centre. All of the patients have access to the TV and can sit and watch the TV, and it helps with the distraction. But our spinal patients have had a very quick diagnosis. They've been transferred from one acute trust to us. It's very rapid. The experience is very negative. And then they're laying flat on the back looking at the ceiling, very disorientated. So having the media centre we thought would be a good distraction. Out of that came that actually when patients are having an EHA completed, they give a much more honest answer if they're able to complete it themselves, but because they were laying on their back, they weren't able to. So we're now able to adapt the stand so that the iPads can be placed in it, they can sign their own consent forms for treatment, they can complete their own EHA, and they've got that media stand for distraction. The drinking device on the other side was another device that came from a patient who said, you know, I've been transferred, I haven't had a drink, and the drinks were there, but they just couldn't see them because they're flat, so they don't even have that visual prompt, and we know how much hydration impacts patient care and their quality of life.
Why do they need to lie flat, and how long do they need to lie flat?
So it was originally thought before the new NICE guideline that patients needed to lay in spinal alignment to reduce any risk to the spinal column by mobilising. There isn't a lot of research in this, and it was mostly based on clinical expertise, but a lot of the time it was around fear, if I'm honest. So for the whole 7 years until this year, we've nursed everybody flat until they've had their intervention. If you've ever had to lay completely flat, it's really disorientating, and especially in a very rapid clinical scenario, it's very harsh. There is another colleague on the NICE committee who has a centre in South Wales, and she is a advanced practitioner physio, and they clinically assess all patients before they are transferred for their intervention, and they mobilise patients per their symptoms as opposed to what the imaging is showing. This is an approach that the guideline has now adopted. So it's quite clear if you have instability pain, which is pain when you move, the patients are going to be telling you that they've got pain when they move. Or if they have neurological deficit, that means that they can't sit. They're the only two groups that don't. Everybody else can sit in a position of comfort and be mobilised per their symptoms. I think it's something that's had a huge impact for provisions, because previously they would have been gone to A&E, laid flat, loaded with steroid, had to be admitted. And it really impacts bed capacity when you have patients that have to be flat. They can't be seen in a fit-to-sit scenario, for example, or in an ESDEC. It had to be on a trolley, whereas now we know that most of these patients are stable. So actually, if they're stable and able to mobilise, it seems appropriate that we keep them as ambulatory as possible. There's also quite a lot of research that, the more ambulatory patients stay, the better their overall functionality and the better of their prognosis. So, it's not uncommon for us to immobilise the patients, keep them flat, and then them develop a HAP, and then die of a complication of a pneumonia or a hospitally acquired infection. And what we don't want to do is think we're doing the best thing by their core compression, but give them deconditioning or anything else that complicates their ongoing management. So drinking and an aid to help patients who are flat to drink is something that the patients fed back to us, and we were able to make happen. Believe it or not, the biggest barrier to the water bottle was the dishwashers on the ward, because they had to, from an infection control perspective, go to a certain temperature, and the dishwashers that were initially installed didn't go to that temperature. So you think of something that a patient feeds back and you think that's an easy solution, it ended up being something quite difficult to actually implement. So there's a short 1.5 minute video that I'm just going to share. In September, in time for the guideline being launched, the BBC came and shadowed us for 3 days. Because we have anything from 4 to 10 referrals a day, we didn't know that it was going to be a really quiet day, and as it was horrendously busy, and they had lots of ability of capturing patient stories. So this is something that I feel quite passionate about, but I can honestly say that the impact of the 4 patient stories that the BBC captured had way more reach than whatever the service has managed to create in the last 7 years. So they followed 4 patient stories all the way through, from diagnosis to intervention and onwards, and they split it over the national news. So a couple were on the breakfast news and then a couple on the 6 o'clock. Lots of media, local media outlets, and it had such a positive response from patients. Being pleased that they had that service locally. So I'm just going to share the patient stories with you.
Our guidelines on diagnosing and treating spinal cancer in England and Wales are to be updated for the first time in 15 years.
To help improve and extend the lives of terminally ill patients.
So this is pioneering. It's changing the way things are done. It's going to be rolled out across the country. How did it begin?
The impact of having a spinal emergency is devastating.
This team specialises in the early detection of emergency spinal cancer across Cheshire and Merseyside. After 7 years, this service has seen the average survival rate increase by 6 months and the quality of life improve, while freeing up valuable NHS beds. Robert had his treatment here earlier this year.
So nice to see you up and about. When I saw you last time, you were in the bed.
Yeah.
It's lovely.
I'm 75 years old. Some of my friends are no longer here, so I'm grateful for every day, every month, just enjoying what we can do. And these people have given us that, haven't they?
Yeah.
Been brilliant.
So knowing that actually we give the Roberts a chance for this not to be, the very end of their life, it means everything to us.
There's moments when I think, I need to do the dishes or I need to do the washing, but I could go outside and blow bubbles for my little girls. You can't ever get back time. So for me to be given these past months with the girls, with Kieran, invaluable. I can't thank them enough.
I'm sure they'll go on to save a lot of people, but couldn't be more grateful.
It doesn't matter how much you watch those clips, you're never really desensitised to the impact that they have. So I think of, Robert's story and how Robert was a patient with an MUO. He didn't even know he had a cancer. The cancer that he was diagnosed while having his spinal emergency was esophageal cancer. Metastatic esophageal cancer has a diagnosis rate of patients not living, 90% of patients won't live a year. And if you have a cord compression, then you originally were 30 days. He survived his cord compression, kept functional, went on to have systemic treatment, and it's prolonged his life greater than that average expectancy. For us, the fact that, he then felt like he wanted to go and get married and play golf and all these positive things, as a centralised service that's non-patient facing, you don't get to see that positive impact that it has to patients. You don't see what that functionality does. Gemma was a patient who had a lung cancer diagnosed at 22. She'd had advanced radiotherapy and chemotherapy, which had given her a life of 10 years before she got her metastatic disease. When she presented in A&E, she was breastfeeding her new baby. Trying to breastfeed flat in a acute emergency department was hell. She had radical surgery and then high-dose radiotherapy and had a really good response, and whereas the average survival now was increased by 6 months. For patients who have surgery and the more radical doses, you're talking years. We've never thought that we'd move from a position of being 30 days on average to that kind of span. So one of the questions that I'm asked all the time is, how do you sustain this? How do we, even if you do get funding for some resource to have a centralised service and then you do grow the team, how do you manage to keep that sustainability when we have such a ever-increasing pressured financial situation? So this board of mess and colour is an annual calendar of education that we deliver, and different types of education. So we have tried to tier the education so everybody who can potentially pass through the pathway as an interdependent service has some level of education, and then we give a bit more bespoke to the different clinical teams who have a bit more of a specialist role within the pathway. What that actually looks like is starting from the university. So for the medical students and some of the AHPs, we do some integrated education with the university. We do quite a lot of regional medical education, so with a lot of the acute trusts and the A&E teams. But the rates of attrition and the rates of turnover of staff, it's really hard to keep that up. So we have to be able to do a lot of different things over the year. We have shadowing placements, we have those that might have conferences that we present at, so that you've got that reach and that networking possibility. We have quite a lot of different formats of repository of information. So at the Clatterbridge website, there's an MSCC professionals area. It's got the guidelines on it. It's got all the policies that we use, the education formats. Same with the Cancer Alliance. So next steps, as in how do we move forward from where we're at now? We're in a great position in that we are nationally leading as a metastatic spinal service. We're able to help other services with that rollout. That's really what my next key ambition will be. The 7 years of educating everybody in our region of the fact that they should consider this being a spectrum of metastatic disease and not worry about the tiny little phases in between, but actually that at any point when somebody is suspected as being on this spectrum, they can get that specialist advice. The fact that the advice is 7-day service has had a huge positive impact to get rid of that unwarranted variation that happens over a weekend. We've never been in a position where we identify their spinal urgencies early enough to be able to implement any prehab, but now we're able to optimise patients. Again, with rehab, if you died in 30 days, you didn't need rehab. Now, because of the life expectancy of patients, they go on to have what is the equivalent of acute spinal issues, like a spinal trauma patient would have. There are no commissioned services to be able to support cancer patients with those issues. So that's something that's working with the Walton Centre and the North West Spinal Network to be able to create. Incidental findings on active imaging and surveillance imaging. There is no current evidence that's in the guideline. There's a national study that was published just after the guideline was published that looks at prophylactically treating patients who have bony metastasis that are asymptomatic, just because it's only going to go in one direction, and what's the point in waiting until it does, because you might miss your window of opportunity. So now we're saying, well, if that's the case, why don't we have a provision where patients can be referred when there's just an incidental finding of bony mets, and then we can have a little look at that drawing table again and see what options the patients have got. In a short time and motion exercise to look at that would be double the activity that we currently have, and given the volume of resource to take the activity that we've got, it's something that we'd have to phase in rather than just say, yeah, we can open the doors to everybody with incidental findings. One of our newest work streams, but a really important one, I think, is the integration of the non-malignant spinal pathways with the malignant pathway. So we have lots of patients now who are living 10, 20 years with their cancer that are presenting to primary care and community teams with a background of cancer and some red flags. And how do you know which of the competing protocols? Is this somebody who's got a back pain protocol that's needed, or a cord recliner, or an MSCC? If you are going to refer into MCAS services, then quite often the wait for that is longer than the week time frame that it's suspected MSCC should have imaging in. A lot of primary care teams can't access imaging. A lot of patients then are sent just to A&E because there's no other service that can mop them up. A&E will say the patient's stable, so I'm going to bounce them back to primary care, and what you end up with is the patient bouncing around a lot of services, having a terrible experience and disengaging. So what we want to be able to do is say, is there an opportunity for patients to be clinically reviewed by those experts that actually can say, this is a sciatica and this isn't something that is a red flag of core compression from your cancer that you had 20 years ago, and this is how we can support you, or actually, we need to put you on a virtual ward or do a scan in a week, and we'll just keep monitoring you until you've had your imaging. There's a Northwest Spinal Network that's just been created to try and bring together exactly that. And our newest team member, who starts on Monday, is a physio who's based in oncology, and that is going to be her role for the next year, is scoping all the services that exist in those non-malignant spinal pathways and us all aligning so that we can interchange the patients and support the patients better through that system. So a oligometastatic translation, what I'm referring to there is there is quite a lot of international research on, now that treatments are so sophisticated. When I qualified, if you had metastatic cancer, your prognosis was significantly reduced and was considered poor. Now it's very possible to have a metastasis in different organs, and up to 3, and you can be treated radically and have greater control of your cancer. So you might have a lung cancer that has a brain met and a liver met and a bone met, and each of those metastases can be treated radically as opposed to palliatively in the carefully selected patients. Because of the nature of spinal cord compression being an end-stage complication of an advanced cancer patient, there's not a lot of evidence research based on it. So for us, it's about how do we translate the other areas that are remotely like what we're doing, and instead of saying everybody just gets a single palliative dose of radiotherapy, how can we carefully select those patients that would tolerate more radical treatments? Since being on the NICE committee for the last 2 years, because we have that active role as a real-world model, we've maintained the relationship with NICE, and what we've started to do is pull together a toolkit of the 20 or so tools that we've created over the last 7 years, so that that can be used for national rollout to support other services. It includes things like a specification and everything down to the business management of the job descriptions that you'd have for each of the roles, through to an audit collection tool, the education strategy, anything that we think has been beneficial to the rollout of our service, so that we can share it wider and help other services to do that. I've just put on there some links to the guideline, and the guideline was published in the BMJ. There's also been 2 further articles that we've published that are on the Clatterbridge website, and also in the guideline, that are around those practical implementation barriers and the toolkits that other services can then use to get started with. So I'll make sure that I leave the presentation with Louise so that that can be cascaded. And that leaves 4 minutes. Welcome any questions, thoughts, comments.
Thank you, thanks. So I've got a few questions.
Yeah,
so,
great.
I mean, in our service, MSK service, I can't remember the last time we had a patient with metastatic spinal cord compression. So
in our service, we have a couple a week.
Yeah, we're missing those. So how do people present? You don't know they've got a cancer diagnosis. Mm-hmm. Is there any way that they present where you can see the red flags a bit different than the cauda equina?
It's a really good question because it's quite tricky because there's an overlap, isn't there? And that's the nature of the beast around the difference between the cauda equina and the core compression. So what we've done in the new guideline is really separate what are those signs and symptoms of indicative of spinal metastasis, so the pains, and then which of the neurological symptoms. They tend to be the ones that clinicians are very familiar with, because if patients are going off their legs and they've got double incontinence, you start worrying. But actually, it's too late at that point in the majority of cases. So you want those back pains to be teased out. But what is a sciatica and what is radiculopathy from MET is quite difficult to tease out. So what we tend to do is say, at that point, so the patient this week that was referred on Monday from an MSK, a local MSK service, had a partial MRI because that's what the protocol would be for back pain. She had a breast cancer 20 years ago. She had some red flags in those pains. So we put her onto our service. We gave her red flag awareness. She has a scan within a week booked for the completion MRI, and then we go from there. But it's how do you logistically set that up so that that virtual ward is then monitoring patients? How do they get a route back in if they do get an escalation of symptoms? Yeah, it's tricky.
It is tricky, yeah. So any questions from anyone?
I had one that just slumped his back while he was standing, his knees buckled.
Can you put the microphone up a bit too?
One patient had peculiar back pain, like as he was standing up, I gave his back a thump and his knees just gave way.
Wow.
So that was fortuitous.
Yeah. That doesn't sound great, does it, for this person?
I think the knees giving way and the falls history is really a good point, because quite often, you know, you retrospectively look through the patient's notes and you're thinking there was screaming red flags all the way along here, but it's quite tricky when 25% of our patients are patients with prostate cancer. You know, a lot of them have prostate symptoms as part of their cancer. Some of them have had systemic treatments that they might get some peripheral neuropathy and some pins and needles, which is a red flag for core compression, but also a side effect of their treatment. Some might have had pelvic radiotherapy, which gives them bladder and bowel disturbances and localized pain. So for the clinicians teasing out what is cancer progression, what is a symptom of, you know, or a side effect of their treatment, what is a symptom of core compression, is this a frailty deterioration, or actually have they started to have falls? And we quite often see a patient history that says, I've been starting to be less mobile and I've started to fall, but actually on clinical examination, their neurology is intact. And that's really difficult, because actually, for us, a lot of the time, when you look back, you know, they have started to take themselves to the bed a bit more, they have had reduced mobility. And so patient history for us is always an included factor. A bit like when the physios and the OTs assess patients and they have some proprioception issues or some reflex issues, those two things on their own are not an indication of core compression, but in a global picture, when there's 4 or 5 symptoms, they start to shape the picture a bit more. So the only symptom that made it in the old guideline of a pain onto the neurological symptoms is the radicular pain. And we had quite a lot of our MSK services contact and say, oh, we are going to be absolutely inundated if we have to scan everybody who has radicular pain and a background of cancer as an emergency core compression. Yeah. And so we said, okay, well, let's pilot it, because most of the time they don't have that symptom in isolation. And in the last 6 months, we've had 2. So if they've got metastatic spinal cancer, they don't just usually come with radiculopathy. It's usually a whole package of other things, yeah.
Wow, thank you. Any other questions? No? Oh.
So, what's your opinion about patients coming with low back pain with a history of cancer many years ago? Do we need to routinely scan them, or?
Yeah, so for the back pain ones, we would scan them within a week, and we'd expect a whole span, the NICE guideline. And this is where it becomes a bit tricky, because the back pain protocol and the cauda equina say that it should be MSK services that are assessing the patients, whereas for MSCC, it's just a health professional who can do a neurological exam. And if you were a patient in a waiting area with cauda equina, you'd get your scan in 4 hours. But if you were the malignancy of unknown origin, you'd get yours in 24 hours. So there's a bit of variation between the competing protocols. We quite often have patients who, as you describe, had a background cancer 20 years ago. The clinician requests a whole spine, and then radiology go, we don't have capacity today, and they downgrade it. And I was chatting in the break about some examples of where that's happened for us. A third of our patients have multiple level cord compression, and it's too risky to assume that their symptoms will be on the area that's imaged. You know, it's not uncommon for us to have a patient who has lower back symptoms or lower limb symptoms and actually have a thoracic cord compression, in which case you would have missed if you just did a lumbosacral imaging. They won't get a scan in 24 hours if they're just with the pains. They will only get a scan within a week. And with imaging capacity at the minute, it's more like 10 days in a lot of services.
I think that the challenge we have is sometimes it gets rejected by the radiologist.
Yeah.
They say it's not justifiable and they just send it back.
And we'll have things like the radiologists say they've had a bone scan in January, what you're doing it for, there's no bone mets, but we have quite a high proportion of patients who have intradural disease or intermedullary disease that you can't see on a bone scan, and you can't even see on a non-contrast spinal scan. So actually, they just have to, that's why having an oncology consultant's opinion to influence the next steps of the diagnosis really helps. The other issue, which is related to your point, is that quite a lot of clinicians know that if they say core compression is a differential, they think they're going to get a scan quicker. So everybody says core compression, and then you've got no scan capacity because everyone is getting scanned for a core compression. So we're working on, with our radiology service at the minute, having a standardised template where it's literally the red flags lifted out of the guideline, and they have to state which of those red flags they have to help the vetting radiographers determine the triage of that scan and how urgent they get it. Aintree, which is our biggest referral centre of our acute trusts, downgraded a patient only just last week, and I rang the radiologist to say this patient has neurology and you've downgraded it to tomorrow, and he said I have 8 on my list today that have query core compression and neurology, so I have to go with what's in front of me. And you know that there's been porcupines being told to get that scan quicker. It makes it hard.
Thank you.
Thank you. Any further questions?
Can I just ask how many people in the room have helped, supported, been clinically involved with patients with spinal cord compression or metastatic spinal disease, just out of feel? So quite a few, yeah. Just one. Right. Great. Thank you.
Well, thank you, Kate. That
No
was
worries.
really helpful.
I'll leave my contact details, and if anybody wants to
and,
contact me directly about anything, please feel free.
Need to read that nice guideline.
Yeah. Or not, because if you go to the website, on our website, I've created a one-page summary of the whole guideline. It's just an algorithm that shows what to do. It's also got a 30-minute education recording of what's the difference between the old guideline and the new guideline, and it's got quite a lot on it, and it's just one page. Makes it easier for a read.
Oh, there's another question. Hang on.
So I work in physio for First Contact, and I did an audit about 4 years ago, and the question was, which do we order? Do we order a whole spine or just the affected area for patients who presented with a past medical history of cancer? So we contacted local hospitals to see what their pathways, and there wasn't much evidence at the time to say about the whole spine, but we decided on our pathway to include whole spine MRI and metastatic bloods.
Right.
And if we request an urgent, we normally get it done between 1 to 2 weeks, really. But is the evidence in the new pathway does state now if the patient has a past medical history of a high suspicion of cancer?
Sure. So it was actually there in the 2008 guideline to say that if you had a suspected spinal cord compression and a history of cancer, that you should have a whole spine. But because of competing priorities for imaging and their resources so tiny, it's got much more difficult. So we made sure it was much clearer in this guideline for exactly that reason. And a lot of, so regionally here, some of our services aren't out of hours services, so getting an MR out of hours or getting imaging if a patient isn't in a centre that, so if the patient's in a hospice, for example, and you don't want to transfer them to the tertiary, to the acute trust for that imaging, that's quite tricky. So yeah, imaging, and for me, imaging access and imaging reporting are probably 2 of our 5 priorities as a cross-organisational issue, because you can't get timely reporting, you can't get standardised reporting. There's too many other competing demands for the radiologists, and they're a tiny resource. And it's the difference between paralysis or not. And if you're paralysed, you're non-ambulatory, which means you can't stay in your active cancer treatments. If you can't stay in your active cancer treatments, you die much quicker. So you have patients who are really well, living with cancer, working, and they have a trauma happens, and then their expectancy is 30 days. It's like catastrophic. So it's really important that, and for us, when we're waiting for that scan, we know, we will have patients on our virtual ward who are being scanned today. We'll be waiting for the scan. We'll be looking at the scan. If there's something on it, we're pushing for a hot report on it. So it prevents that delay. But yeah, you can absolutely push for a whole spine.
Yeah, we have. Thank you.
So for example, once you scan somebody, it's normal scan.
Yeah.
There's something to say that if the symptoms continue, then when do you scan again? So it's like a 6 monthly or 1 yearly, or
so we wouldn't surveillance scan for somebody who, if once we've eliminated that it's of a metastatic spinal nature, then it's back to the non-malignant pathways to work out what it is.
If the scan is normal today, 6 months later they will not develop to a malignant.
No, you can never guarantee that, but there's certainly no evidence to surveillance scan those patients. But what they would have if they had active cancer would be natural active surveillance because of their cancer management. But what you can't do is prophylactically scan patients.
Not as a prophylactic, but what I mean is that as a FCP kind of scenario, you have a patient who have a cancer, you have sent them for scans, bloods, everything normal today.
Yeah.
But 6 months down the line, they come back and say, my pain is still the same, it's getting worse.
Well, if it's getting worse, there's your indication to scan again. But if whatever it was that they presented with, you'd be trying to find the source of that. So there's a patient that was referred today who had severe neurology on every aspect. And I was absolutely convinced he was going to have a core compression, a prostate cancer, back pain, all the symptoms. And we scanned him and there was nothing on his spine. And it's like, well, you still need to find out what's wrong, where his neurology is coming from, because he still has unexplained symptoms. So and it would be wrong of us to say, let's keep hold of them in an oncology pathway, because we wouldn't be the experts to be able to identify what that differential is that's causing those symptoms. So it would be back to the clinical teams.
It's a tricky one.
Yeah, it is a tricky one. It's the mixed picture that's tricky when patients have metastatic spinal disease and non-malignant issues, osteoporotic fractures, disc issues, and they're symptomatic, and teasing out what's causing their symptoms. Do you radiate? Do you not? Yeah.
Well, thank you. That was really, really useful.
Yeah, thank you very much.